So how are you?
Fine. Hope the same for you, my friend.
Yeah, all good, all good. All fine here. So we have many people online, a few people in the room. So very similar to what we had in the COVID times, where you already have given fantastic presentations. Not the first time. So thanks for coming again. Excellent to see you here. Um, Good. Maybe just a few words for your information. So we are recording that, the presentation, and I hope that's okay for you.
Of course it is, no problem.
Fantastic, fantastic. And we make it then available to the students afterwards. Would you be okay for this to be also available to other speakers? I mean, Kawai Kwok from Hong Kong asked, for example. You okay with that? Good. Okay.
No problem at all.
Yeah, I mean, please feel free to say if anything should be cut out, because Pietro, for example, told me to stop the recording for a few minutes at some point. Yeah, let me know. Yeah, good. So then maybe we'll move as quickly as possible to see your presentation. Yeah, it's really great pleasure to have you here today. We have been working together for many years. I think we started around 2011, 2012, preparations for our big StiffLab project, where we collaborated for the first time. And that was, of course, a fantastic experience. Um, and now we have another grant coming up, starting in January. So yeah, as I said already to you, looking forward to working with you again on that project, which of course also is in the medical robotics field. And yeah, good to have you on board again. Good. Then I think I'll leave it to you and yeah, pass over to you.
Just one question. You told me I had to speak to students.
Yeah.
PhD course. I read here Elena Demomi. Is she also a student of your PhD or?
Elena is here. Very good. I didn't realize. Hi, Elena. No,
Great.
Elena is the Elena Demomi whom we know from Milan. So, Elena, thanks for joining. Fantastic. And maybe you brought also some people with you, which is also fantastic. So it's mainly third year and fourth year students here at Queen Mary, so not PhD students. And this is part of a program that we are having here, part of a module, and which is called Medical Robotics and Surgical Techniques.
Tell me if you see my screen.
Yeah, we can see it. It's still in your presenter mode, but now it's in presentation mode. Perfect.
Presentation mode. Okay.
It's perfect.
Yeah.
Over to you.
Too much technology for me now in my office, so
no worries. It's all working.
Very good. So first of all, it's really a pleasure for me to share with you this presentation. It comes from about 25 years of activity in the field when I was a PhD student in Tübingen. I had the pleasure then to meet Kaspar, and we did some development together. Most of the things you'll see here depends on my strong activity with Scuola Superiore Sant'Anna. That's where I met Pietro years ago. But not only. In the last years, you'll see that cooperation of these centers with many engineering centers has grown, for instance, Elena, and I hope it will grow even more after my presentation, hoping that I stimulate you in ideas in which we could cooperate. That's also why I'm here. So I have some disclosures, but unfortunately or fortunately, very little ones. Now, the first thing that you have to ask yourself when you start to think about robotic surgery is, why would you like to use a robot? Because it's a fashion, or what do you really ask the robotic technology to do for you? And then the possible answers could be to do in a better way things already done by standard laparoscopy, or to do more often procedures in a laparoscopic way that require lots of skill under standard conditions as they become easier. Don't forget that not always when you start a laparoscopy, you end the same procedure under laparoscopic conditions. or, and that's also possible, and in my opinion, the most appealing indication, to enable procedures of evident benefit for the patient, which are not possible today with existing endoscopic technology. And I am alluding particularly to endoluminal procedures, meaning using natural orifices like the mouth or the anus to introduce miniaturized robotic platforms. Now, today, the chief, Kaspar, asked me to focus mainly on laparoscopic things. That means everything that is done inside the abdomen through the abdominal wall. And that's what I will do. But I will leave some few slides at the end to go more into details of what I'm saying. So you have to know that the first surgical robot was conceived in 1972. And it is very sad to say that not all the reasons why this was done were, how do you say, easy to share, in the sense that the big push to investigate in this field came from the war situation in which the US found themselves after the Vietnam campaign. This is where the funds for promoting this technology came from at the beginning. When I joined 20 years later, the Tübingen group led by Gerhard Buß, I had the pleasure the very first day to participate to this demonstration in an animal lab in Karlsruhe, in which he was using the first robotic platform for laparoscopy. So you see he's manipulating small bowel with these that today I think you would call continuum robots, flexible but rigid, made of metal. And you see that the interface was also not ideal, quite cumbersome, not exactly capable of miniaturizing the gesture of the surgeon. I don't know if you noticed that this was the first attempt of using 3D technology. Gerhard Buß here is wearing a first version of what today you would call goggles to have a 3D reconstruction of what he is seeing. You know that the history then had an acceleration when in 2000 Intuitive had an FDA-approved device to put on the market, which for some time had the competition of computer motion that developed instead Zeus, which was a system derived from an optic positioner called ESOP, to which you could attach standard laparoscopic instruments and therefore perform surgery in a platform with 3 instruments. Now, the history of Intuitive, I think, is known to all of you. Main achievements were 4 different generations of the device, but the concept in the end is always the same. They have an endowrist technology at the very tip of the instrument. Today, they add a second console to allow better instruction, better education of the technology. And now standard is the use of 4 arms that you switch from the control by foot pedal from one to the other. Now, the success of the campaign, it's known to all of you for sure. There are today much more than 6,000 robots installed worldwide. Italy was a pioneer in this in former times. We have experience with it since 2001, but today the majority of them are in the US. And it is also interesting to see that the curve is also rapidly growing, as you see. We have data till 2019, but you see that just in 2019, more than 20% was the increase in number of systems placed. Now, it's interesting also for you to know which are the application of this technology. In former times, the system was developed for 2 indications mainly, that were thoracic surgery, especially cardiac surgery, and general surgery. But after a failure of finding good indications in that field, the vast majority of the procedure were performed for several years in the field of gynecology and urology. And it is only recently that general surgery became again the #1 application of robotic technology with Intuitive system, once we have introduced the feeling that you could use the system to perform the most simple procedure that we perform today by laparoscopy, which is hernia repair. So all the defects of the abdominal wall. This increases the market hugely, and Intuitive made a fantastic campaign in sponsoring their technology for this application in the US, where the reimbursement system makes it very easy to have the entire technology paid for this application. In the research field, Intuitive is known in recent years for having invested a lot in the SP technology, and at the same time also on ion technology, a strong start to peripheral lung biopsy. Now, the Da Vinci SP, that stands for single port, has been extensively used by John Marks in the US. He performed first left colectomies with it. This is a video of the technology that I'm pretty sure that all of you are aware. It's a 4-arm robot. One is a dedicated binocular vision optic, and 3 are tools that can be easily interchanged that allow you tissue manipulation and dissection. Now, the thing that you would notice immediately is that the interface that is exactly the same of the Intuitive standard that today is called XI, the interface controls the robot that requires quite a long area to set the system in place. So only once the system is settled, you can operate it, but this cannot be done in really narrow spaces like you see here. For instance, what you see here is a surgery inside the vagina, and you can see that the system is completely out of it, and only the 2 arms are inside the vagina for tissue manipulation and suturing. Otherwise, the indication for which this was designed is the transumbilical part, because there you have a huge abdominal cavity to displace all the technology. And this is John Marks in person performing his surgery through this single access in which he could put this 35mm trocar inside that embeds all the 4 arms. And now you notice immediately one of the problems of the system. You have seen a further instrument that was passing inside the vision field. And this is one of those technologies that today are not available for the single port Da Vinci. The arms are bendable in 2 points, as you have seen, so they can be S-shaped. And those 2 arms allow to achieve a good triangulation towards the target that we want to dissect. The system has enough strength to lift also heavy abdominal tracts, and therefore it's routinely used for even tumor surgery, cancer surgery inside the abdomen. But this that is called advanced device, which is now available for the standard Da Vinci, is not available for the single port Da Vinci yet. It is extremely interesting, a very similar concept for single port that comes from virtual incision. This is the Mira robot. As you see, the robot in this case drops from the roof of the OR, and the instruments are already embedded there so that you can exchange them, but not the same way that Intuitive did. The only thing that you really insert is the optics. That is again a 3D optic, and in this case you only have 2 arms and not 3 arms like we had before. The maneuverability is very similar. The instruments are not 5mm like the one that embeds the single port Da Vinci, but this allows to have sufficient strength and keeping the same precision that is required for performing this kind of surgery. This instrument has just been introduced in the practice on human cadavers and will be soon launched for real clinical activity. Behind this technology is my friend Dmitry Oleynikov and Debbie Keller, who is one of the SAGES cooperators, so the American Society for Endoscopic Surgery, with our society, the European Association, the IS, for which I serve as General Secretary, is also doing part of this demonstration. So I'm awaiting feedbacks from her the next days. If you need to know what are the advancements of the Da Vinci platform over the last 20 years, the most significant one are the one that I presented one moment ago, but related just to the standard Da Vinci, as we call it, two things have to be mentioned. Today, Da Vinci offers also the possibility of stapling devices. That is something that is in the habit of the surgeon, and so it's very So it's very difficult to get rid of these. These are extremely useful, for instance, to close rectal stumps or to access narrow spaces in which also suturing would be difficult, and allow to close and cut at the same time. As you see, these devices allow to close U-shaped into B-shaped staples to compact and compress the tissue together. Now, what Da Vinci does, they offer now staples that are fully governed by the console, so by the operator, including the firing of it, and they are also bendable, as you see at the tip. The other very important achievement is the one that I mentioned before. Today, it's possible to have a real vessel sealers up to 7 millimeters in diameter of vessels that therefore can be cut without the need of suturing or clipping to prevent bleeding. The only alternative to the Da Vinci system is the Senhance today available, but the Senhance is already at the third generation as well, in the sense that it has been achieved after bankrupt already twice by a further company. I am particularly into this technology because the needle holder that they have is designed in Tübingen, and it is the robotized version of the Radius system that you also can find commercially available as a mechanical tool for standard laparoscopy. It has exactly the same design of the Da Vinci needle holder, but much slimmer and much more user-friendly. The entire system is much more slimmer and user-friendly than the Da Vinci robot, as all the instruments are just 5 millimeters and not 8 millimeters like the standard Da Vinci. But last but not least, we have to mention the CMR versus system. This comes from Cambridge Medical. And this has a completely different concept. While the two systems that I've shown you before are all standalone on a single platform, and all the arms come to the surgical field like an octopus, here what you have is a completely different idea. That is to have as many arms as you require for your procedure. Each is standalone, and each of them has an interchangeable tip to be removed. Now, the advantage is that positioning of the arms is absolutely easier and can be done in any OR configuration, because the space requirement is completely different from a bulky single robot. The technology to control is more or less always the same, provided that patents are respected, and CMR is now growing a lot in experience, particularly in gynecology field and in general surgery field. Although some of the instruments are also not yet available. For instance, we do not have for this robot the availability of advanced sealing devices like the one that I've shown you a moment ago for the Da Vinci. The dexterity of the system is absolutely identical to what I've shown you before. For instance, we are here down in the pelvis, one of the most difficult phases to be performed by standard rigid laparoscopic instruments. And you see that the area is at least easily reachable. There are other players on the market. Medtronic. Medtronic very recently introduced his robot. It's called the Hugo robot. And this is mimicking very closely the standard Da Vinci system. It's just a little bit slimmer. The console is much more user-friendly. But the first feedbacks from my friend Yoav Mintz, who has the first device, who also was part of the STIFLOP, Kasper should remember, who has the first device installed in Europe and Asia, and he is based in Israel, are very good. He is using the system for hernia repair, as I mentioned before. The dexterity is absolutely fantastic. There is still lack of a lot of tools. At the moment, there is no ligature available, but there is only monopolar and bipolar technology. Medtronic is also engaged in single port technology. They developed the Titan system. The Titan system comes from the standard design of flexible endoscopes and tries to mimic what Intuitive did with the single port device, the SP. Now, the advantage of the Titan compared to the SP is that, well, forget about this very old-fashioned console. The advantage is that the dexterity of the instrument is much closer, but still it has the same drawback, in my opinion, that it requires a lot of space to set. I go back a little bit in the video and stop here. You see that this is the trocar that embeds the three instruments, three, not four like the Intuitive one, but have a look of how much space do you need in front of it. So this means that you can use the system not through the anus or through the mouth, but only in large cavities like could be the abdomen. We know that J&J is working strong with Google on deploying their own device. I heard rumors about it, not enough to declare much of it to you today, but I'm sure that it will be a masterpiece. The last system that I would like to present to you is the most user-friendly. Have a look how easy it is to interchange the instruments. It's based on a similar technology to the Da Vinci one. As you see, it's only the tip moving, so it's not a continuum robot like we mentioned before. And it's based on the same idea of CMR to have each arm separately installed around the patient. Now, the nice thing of this device, I show you again, is that you can perform laparoscopy with standard instrument, and then very easily you can advance the robot only for part of the procedure. For instance, if it requires major precision, just performing the suture of the bowel, it's easy to do this with this device for just part of the procedure, while the rest of the procedure can be performed by standard laparoscopy. I am not happy at all, instead, with the new fashion that appeared recently on the market. That is, for instance, the example of the human extension, so-called handheld robots. To me, these are not really robots. These are remote-controlled, hand-controlled, remote-activated devices. Means that the same thing, in my opinion, could be very easily done with just mechanical technology, and you don't really need to have this electrified that requires a lot of weight to be held in the hand of the surgeon. So the movement that you see there, that is this rotation of the tip, is done electrically, but I don't consider this enough to consider this a robot. In fact, it is very cumbersome to use it, and I was the first to use it in the world for transanal surgery, and we did only 2 cases, but I found it extremely difficult and not intuitive at all to be used. As I mentioned before, the development of single port devices goes parallel now to the development of general surgery robots. But you have to leave me a few minutes and then I finish to introduce to you what it is to me the most appealing concept, that is to miniaturize robots and let them pass inside the organism without making scars to our body. And as you see, there are a number of devices. I mentioned before the Eon for bronchoscopy or the Auris system, but there are two, in my opinion, that merit mentioning here. One is the EndoQuest. In former times, it was called Colubris, and the other one is the MedRobotics. To be honest, there were at least 3 other systems that failed to come to the market, but required to be mentioned as well. The pioneer of all the endoluminal robots is the EndoMaster that was developed by the University of Singapore, just as the Anubis core that was instead developed together with EARCAD by Karl Storz, and finally the K-Flex from Seoul, Korea. Now, these are historical images that you find on the net by my friend Philip Chiu, who is now the president of the Society for Endoscopic and Laparoscopic Surgery of all Asia. So a huge organization. And the video that you see now is the video that he posted on August on the most important journal for gastrointestinal endoscopy, that is Gastrointestinal Endoscopy Journal, in fact. And here he insists that finally the robot has achieved sufficient improvement to be used clinically. Now, to me, this is not at all convincing. I do not see control of the margins around the tumor. I do not see exactly how to prevent, and then after it happened, how to control the bleeding. My imagination is that the bleeding was controlled with some other technology than the one that my friend is using in this exact moment. And frankly speaking, you may not be aware of how to do these things, but I would say that this polyp really did not require any use of robotic technology. It could be just simply snared out with a monofilament metal snare. I think there is still a lot of work to be done in that field. I'm sorry to say instead that this piece of technology developed by Karl Storz, that is this oyster concept of an endoscope, was abandoned. You know that the companies will never tell you that they have abandoned the project, so all the projects are generally simply in a standby situation. But what it is that what you can achieve with this system is unfortunately not precise enough. And I know that they had some technology problems in having good vision with their device, and also the dexterity of the arms were considered not sufficient to justify the application of a similar costly technology like the one that I'm showing to you. My preference goes instead for the K-Flex device that comes from Seoul, as I said. This is really something amazing. It's a miniature robot. This is at a very preclinical level, what I'm showing to you. And it's very easy to handle it with this prototyped console. It is S-shaped. You see that there are two parts that can be invariant along the bendable part. The only thing that I would complain, but without having direct experience with this technology, is that I am afraid that these two arms that derive from biopsy forceps of standard flexible endoscopy are a little bit too weak for how they appear to me. And I'm not really sure that they could be suitable for real tissue manipulation. I have the largest experience in the world with the use of the only available on the market system for endoluminal procedures, which is the med robotics. Unfortunately, the company had bankrupt during the COVID pandemic, but as you see, this is a different concept from the others. We did some 30 cases. The aim of the project was to bring a surgical platform above the rectal tract, which is a rigid part of 15 centimeters, and going ahead, over the recto-isthmial junction with this technology. The aim was to do some mini surgical procedures, including tissue manipulation at that level. But in reality, the dexterity of the endoscope, which is the robot itself, while the two instruments, have you seen, are standard mechanical graspers and dissectors, the dexterity is limited, and therefore it was almost impossible to achieve that aim. We were just developing the 35 centimeters long device, just as well as we were developing the 16 millimeters in diameter device for upper GI application. When the company had bankrupt, we still have these prototypes here for some engineer who would like to play a bit with it and maybe achieve some good improvement of that technology. What we were able to do with it, you see, while lifting these what we call carpet-like lesions that are benign tumors, while lifting them so to separate these tumors from the outer part of the bowel, so avoiding the risk of perforation of the bowel, we were cutting it with just monopolar devices shaped as a spatula, so not as a hook, but just as a spatula. And you see that very gently, although the system here is purely mechanical in the dissection tools, very gently we could respect the muscle layer, performing a very precise anatomical resection of the bowel. And with this technology, it's also possible to stitch, although difficult when required, in case you perforate the muscle layer for an inadvertent dissection. So you see that once you have stitched through the tissue, you rotate the grasping forceps around the thread, and here you are. You take the tail and you can pull and close the knot. Very convincing. This is the device that I was mentioning before. This is 35 centimeters long, but what it is disappointing, differently from the animation, what you see is that the device can bend only in one direction, and it is never as shaped as it should be. The maximum flexibility is 90 degrees, which is also, in my opinion, not sufficient. So a lot of work should be done in this field. I think much more convincing today is the Colubris system. I had a long chat with them for a possible cooperation yesterday evening. This is also a 7 degrees of freedom multi-articulating instruments through that are passed through the scope. But have a look. This is extremely more convincing because the instruments are very tiny and they do not require such a long space to deploy. But what it is not convincing is the fact that they still have to develop a full portfolio of instruments, because by doing this resection with just scissors, what it is, the result in the end is that there are at least 3 holes at the bottom of the dissection, 1, 2, and 3 in a moment, which is absolutely not acceptable. What we want to do, we want to do this to achieve much better precision in dissection. And this is why precision attracted my attention, and I approached a company that was based at Imperial as a startup and now moved back to Shanghai. This is called Precision Robotics. The guru behind is Guangzhou Yang, which is certainly known to most of you. And they developed two different systems. This is the system for transrectal application that has a binocular vision at the patient, as you see. This is how the system is shaped. These are the grippers. And this is the mechanics that go in and out the anus, and that allows you to bring your technology there. They are continuum robots. I personally think that a bit of work should be done in better controlling these instruments that, to me, allow too much of a dexterity for such a narrow space, like you see in this image. And just to show you how the system works. This is the inner image. Similarly to what I've shown you before, you can pull threads and knots, and this is the system that we have instead, that is both to be used for transanal and for transumbilical procedures. That means that you can use the system also to do hernia repair or a cholecystectomy. The precision of movement is absolutely unprecedented for me, much more than you can achieve with the med robotics, for instance. And this is myself trying to play with it. The 3D video system is now the one to which we are all acquainted with. That is the Sony, that allows you also to have at the same time 2D and 3D. And as you see, it's a little bit struggling at the beginning, as all the systems, despite intuitive, they all require some training. But you see how relatively easy you can handle the needle, and you can start your continuous suture. So there is a long activity that we are doing exactly in these days. So to compare all the systems that we have in our lab, that is this one shown here, where we have a man robotics, we have a Da Vinci research kit, we have now two KUKA robots, LBR, sorry, for making comparisons of achieving precision dissection and mainly precision suturing through robotics, always aiming to achieve automation. So it is not really clear to me which is the right way to go. I would say that the full robotic system is by far the one you should prefer. I don't like very much anymore the concept of the med robotics of a pure robotic endoscope, but with flexible arms, mechanical flexible arms. In fact, the next generation that was about to come when the company had bankrupt was already equipped with robotic technology also on the arms. Now, all the things I explained to you or that I displayed to you today are not robots, in my opinion. They have no autonomy. I think it's not difficult to work possibly together in achieving at least task autonomy, so what it is level 2. And I think it would make really the difference for us. And this is why we have these 3 projects now going on here in Turin on different platforms, including a personal shaped here in Torino together with Scuola Superiore Sant'Anna, which is the robot for endoscopic dissection, of which we are now at the 2nd generation that is not displayed there, that has a concept of being a hood to be placed at the tip of a standard endoscope, but with all the functionalities that you have seen in the different systems that I've shown you today. A big thank goes to my 2 mentors. One I have the privilege to work with is Mario Morino, my current chief, and of course all the people that liked to share with me some part of development and achievement, like Elena, and of course like Kaspar, the host today. Thank you very much for your attention.
Fantastic. Thanks a lot, Alberto. Excellent presentation. And wow, I've seen many presentations from you, but this was completely new again. So thanks a lot for putting all that effort into preparing that. So we have some time left for questions. And as previously, if anyone wants to ask a question, please raise your hand or just open the microphone. And I'm happy to, or put it in the chat. Yeah, also no problem. I'll start maybe. So maybe I come back to this point about automation and being autonomous, and you're saying these are not real robots. So you're sharing yourself now somehow, yeah? Isn't it?
Yeah.
If you want to unshare, well, up to you.
I don't know how do I unshare?
Maybe if you go to the top of the, or maybe.
How do I unshare? This is my question.
I don't know. Yeah, maybe share yourself again, and then, or maybe I share my screen, and maybe that stops it then. Where's my screen?
Stop now? No, stop share. Stop share. Now it's stopped.
Now I'm sharing my screen.
Okay. Sorry.
No worries. I'll just give me a second. I'll press this button here, and that should solve the problem. Yep, perfect. Good. So these are not really robots for you, you're saying. But then on the other hand, we have this fantastic intuitiveness in the Da Vinci robotic system. And you were talking about the Senhance robot, and in a very positive way. But my understanding is they don't have that. So effectively, you're back to your old style of laparoscopic thinking to make sure that you twist the end in the opposite direction because you are going through this pivoting point. So what's your thinking about that?
Today, I wouldn't call all these robots. I would call them telemanipulators. I think it would create much less confusion. I think that the reason why we do that, it's also for publicity, and that's why we surgeons are confident and prefer to call them robots. There is no proof at all that what we achieve today is more precise than what we would be able to do with standard laparoscopic instruments. I try to say it in a politically correct way. The reason why for some years the urologists were the top users of robots relates to the fact that for years they refused, they were not keen in getting trained with laparoscopy. And I'm of course not talking about excellent urologists like our common friend Prof. Gupta, but the reason why they preferred to apply robotic technology to their patients was strictly linked to the fact that their background in standard laparoscopy, let's say, was limited. So they referred to the use of a robot all the gainings that usually you get by standard laparoscopy. No big scars, restricted dissections, and easily fast discharge of the patients and so on. But these are related to laparoscopy, just as I don't like when they say with robotic technology you have more precise because you have a 3D vision. 3D vision has nothing to do with robotic technology. You can have 3D vision also in laparoscopy. So for me, the achievement there is really the precision in action. And this is where, in my opinion, we invested less in the platforms that I've shown today also, that are also coming on the market. Then the question may be how much precision is required for the procedures that we want to do routinely in general surgery. In other words, when you do a total gastrectomy, do you really need to have a precision of 0.1 millimeter in maneuvering your instrument? Probably not. Probably other things are more effective. What it is sure is that there are several tasks that require lots of training, and some of them are so easily done by routines in using robots. And one, I've shown it to you, is just stitching and knotting. That would save a lot of time, and there is no discussion that a good robot can do these things much better even than the more experienced surgeon, because it will do in a repetitive and validated, reliable way. So why not to do it? Why not to use robotic technology for tasks that we can identify during our procedures?
Okay, no, I take that point. Of course, that would be the right way forward, I suppose. I mean, I suppose once we have specific approaches to carry out certain tasks, which you can achieve by pressing a button, I agree with you. But on the other hand, I mean, I have tried it myself. Laparoscopically, I am so useless. I can manage to make a knot if you give me enough time. If I use the Da Vinci robot, it takes 1 minute. You know, I do it, and it was a. I mean, I think I did only one knot with a Da Vinci robot, and I was able to do it straight away. And so that kind of intuitiveness which is built in there. I mean, I see it as a certain autonomy there, which is in the collaborative kind of phase there between the human and the robot. But you think that is the wrong direction to go, yeah? Okay, good.
But there's also one thing that I have to make clear. I think I am the worst person to test if a robot is good or not. Because with 25 years of experience in laparoscopy, I always have the innate tendency to replicate what I already do in laparoscopy. This is why now, since years, of course, I want to try every device myself, and I want to indicate a little bit which is the direction of research. But I have the pleasure here to have, and you know, tens and tens of residents. And finally, let me be very, very proud of it. I do have 2 engineers that are doing their PhDs here in my lab, and they are my preferred testers. I tell them what they have to do. I don't tell them how to do it. And I want to see how they manage to do these things with a technology that is different from what I've been trained. I have no difficulty in admitting that they perform with precision robotics much better than I do.
Good. Okay. Yeah. No, I see the point. I'm of course a total novice. I'm not even a surgeon of it. Good, but maybe just quickly also to the human extension system that you mentioned, which I think looks very promising. But again, I look at it from my perspective, and you tried it out, and you said after a long time using it, it was just too heavy. But maybe if those problems were somehow overcome, do you think there is some scope?
Again, I am biased because being one of the designers of the radius system that does exactly the same things but in a mechanical way, maybe I'm influenced by this previous experience. I don't see much of an advancement compared to that. Again, this is designed by one of my best friends, Amiki Zold, okay? So I always have difficulties in being honest in judging this technology because of that. But I think that what they did, they pushed a little bit the boundaries. They wanted to use the word robot for marketing perspectives, and that's why they electrified it. But what they had in principle in their minds, and this is something that you have to know, they wanted to replicate exactly the platform of the Da Vinci with the control of the Da Vinci on the patient. This means that when they wanted to bend the instrument internally, you had to use your handle and move it internally. Exactly like when you're using the 2 hand controls of the Da Vinci, if you want to move the instrument in, you need to move your hand in and out, okay? Now, the thing is easily done in an intuitive way if you sit at the console. But me, as laparoscopist, when I had my two instruments there on the patient, if I wanted to bend the instrument in, what I used to do was this, for the level mechanism. So the first version of it was impossible to use for us. So then they re-projected all the software, and we had the second version, but again, it was very cumbersome to use it. So truly what we did, we blocked the mechanism in a bended way and used it pre-blocked. But when you do that, I really don't see the reason why I should not use a standard mechanical instrument.
Maybe a way forward could be to have a system, especially for people who are as experienced as you, that behaves like a normal laparoscopic tool, but maybe has a button that you can press and it makes a knot automatically or does some suturing for a few minutes.
That's how it is. That's the new version of it now. It's shaped like that. And what you can do, you have a level mechanism through which you obtain the rotation of the needle holder, so to achieve that easy movement that I've shown in my video. So it's a compromise, you see. It's not a full robot, but again, we said task autonomy, didn't we? So it has some task autonomy.
Good. Okay, we have only a few minutes left. I'll do one more question. Suturing versus stapling. You mentioned both. Is suturing on the way out? Can we do everything with staples, or will there be always a need for suturing?
Okay, you touch again a wound, in the sense that when Intuitive came out, the message was, well, you will not staple anymore, you will not use sealers for vessels anymore, because it's so easy to knot, to tie, to stitch. No, that's not true. There are situations in which the use of staplers is mandatory. You know what I'm talking about, but for the others, when you go down into the pelvis, remember all the theory behind the shape of the sacrum wound, bone for the stiff flop. In that narrow area, to cut the rectum and start stitching would be a nightmare, even with the easiest technology to stitch. When you can isolate it from behind, place a staple, and then with a knob or with a button, activate it and fire and cut and staple all at once, there is no discussion that that's the way to do it. And so in the end, they had to rethink their philosophy, and they are more and more mimicking standard laparoscopy in these things. They have vessel sealers, they have staples. So as you see, the distance between laparoscopy and robotic surgery in a way is getting narrower and narrower. But we are happy with it, because I don't want to give a wrong message. In 10 years, all laparoscopic surgery will be robotic. And I'm happy of that. I just want all to feel pushed to advance the technology at that level at which it will be useful and not fashion.
Very good final words. Thank you very much. So fantastic presentation and fantastic input from you. Thank you very much again. And I thank also all the participants. And that's the end of the session today. Thanks a lot. See you later. Yeah. See you, Alberto.